standard ET tube with standard stylet that comes packaged with these ET tubes. We were always kind of taught to put a slight hockey stick bend at the end of your tube to help accessing into the tracheal opening a little easier. Once we're set up and ready to go, we pre-oxygenated our patient for at least 2 minutes of high flow nasal cannula or nasal cannula and non-rebreather mask, at which point I'm going to start inserting the blade using McGrath. Anytime we intubate, we're always going to be coming in from the right side, sweeping the tongue over to the left, and then we're going to start advancing our blade down. For this blade, I know this McGrath, I know typically tends to go a little bit deep, so I tend to put this in all the way, and then as I am coming out, I'm slowly lifting and I'm looking for those cords to drop. So I have the cords in view at the top upper part of my camera. I can see the tracheal opening. I know below that is the esophagus, at which point now I can go ahead and start advancing my tube in. I'm coming in from the right side of the mouth, and I can visualize it heading right towards the cords. And it's important we watch that past the cords. I want to keep this in so we can verify passing of the cords, but I'm even going to leave that in there when I remove my stylet to confirm that I still have placement in the cords and just keep that validation in there. Once we remove our stylet, we can inflate our syringe. Once we confirm proper placement with negative epigastric sounds and positive lung auscultation, at which point I'm comfortable removing the blade, and I can go ahead and secure my tube, noting where I'm at the teeth. So next, we're going to be using our rigid stylet here. So it is just that. It is rigid, does not really bend here at all. As I insert the ET tube from the right side of the mouth, same thing coming into the left here, I can again visualize the tip of the ET tube coming to the cords. Important thing you note about the rigid stylet is the stylet itself should never actually pass through the cords. Once I actually have the tip of the tube right in the opening of the trachea as I do right now, I'm simply going to pop the top here of the rigid stylet, and as I lift, I actually push my tube in, and as I get to where I see the black line pass through the tracheal opening, I can then point this down towards the feet and pull it out, all while maintaining control of my ET tube here. So this is our bougie intubation, at which we're using a bougie stylet to access the trachea. We have our ET tube pre-plumbed here at the top, so once the bougie inserts through the trachea, we can slide our ET tube down over it into the tracheal opening. Important with the bougie here, we want to have that slight kind of hockey stick bend at the end. That's the end we're going to be inserting down into the airway. Again, as I insert, kind of coming from the right side of the mouth, controlling my tube until I see it make to the entrance of the trachea. The tube then inserts through the trachea. I'm going to put this down until I meet just a little bit of resistance, watching that black line past the tracheal opening, noting my markations at the teeth here, which again, we're about 23 at the teeth. We can go ahead and pull our bougie cord out, inflate our cuff, and auscultate as appropriate. So this is our butterfly BVM. Out of the package, it's going to come like this. We do have 3 different size masks attached to it. So important thing to do, first thing, we're going to squeeze the bevel here to a closed position, and then we're going to adjust it to our patient size. Starts off as our standard large patient. We can go down to medium or small adult. Then we have all the colors that match up with hand tebi and or your Brasilo tape to appropriately ventilate the patients. Once we have our size selected, we can let go of this, and we can remove our tag, and we're ready to begin ventilating our patient. So butterfly BVM, so you can see standard size patient here, attach and squeeze to give a breath. Again, it only allows us to give, for this setting, is 550 mLs of air, so we have a lot more control of the amount of ventilation we give and the volume of air we give as we did to our standard BVMs, which we've had in the past. If, say, we don't see appropriate chest rise and fall with this setting, say our suspicion is that we need to give more volume of air or higher volume of air, we can close our bellows all the way again, keep them closed, select our new appropriate size, and you notice the bag will expand a little further than before, thus giving us that more greater volume we needed. Auscultating breath sounds after we have hopefully proper ET tube placement. I always want to start in the epigastric area. So my partner squeeze, I'm listening, want to make sure I don't hear any sounds or gurgling in the stomach. Once I've confirmed I have no epigastric sounds, I'm going to start moving to my lungs here. Personally, I start with my left lower, squeeze, then I go to my right lower, squeeze, left upper. Good. Want to confirm lung sounds in all fields. I want to make sure I also didn't go main stem with my ET tube. So a lot of times when people listen to the left side first, but it is important just to auscultate in all fields, starting with epigastric first. As far as CO2 goes, it is still the gold standard of airway confirmation. Your reading should correspond with squeezing the bag valve mask, and hopefully be within 35 to 45. If you don't have waveform capnography, you should immediately find out why. If you don't have waveform CO2, you don't have an airway.